should start now. No, it's still 12:03. So why I'm in rush? So probably it's because I'm not seeing also how many people are attending. So
there's 35 online right now, including us, Dr. Hessami.
yeah. So these are my disclosures. Like every company involved in dermatology, and this program is supported by Miravo. And this company changes their names a lot, you know, from Altius now Miravo, and they actually have a lot of interesting things related to family medicine, like iron supplements and painkillers like headache. But in dermatology, they have Soriaten and Blexten, and these are two things that we use a lot. So I'll go on objectives, and basically, so I kind of officially start my talk now. So we are talking about cutaneous manifestations of COVID-19. And I presented this talk in June to emergency doctors of like our hospital. And it's interesting, since June, like at that time, there were about 19 articles when I did the PubMed search, and like few case series. Like this time when I searched, there were 200 articles just in PubMed. And if you check like Cochrane review and, you know, systematic review, you find also more information. But obviously, because we are actually dealing with a pandemic, and there are many reports from all over the world, and there are a lot of awareness and a lot of articles, and it's easier to publish an article now when there is name of COVID on it. So we're also going to review urticaria, and I give the connection and the reason behind that later on. So everybody knows that about now SARS COVID-2, like COVID-19. And on March 11, as you know, WHO announced a pandemic of COVID-19, and we're still dealing with it. These are the numbers from last night. So about 112 or close to 113 million population all over the world, they had COVID. The number of deaths are 2.5, around 2.5, and recovered like 88.23. So, but probably there are numbers like 5 times these numbers. So all over the world, probably around 500 million population, they had COVID. And we still, like for a population of the world over 7 billion, so we still have a lot to go. And that's the reason we are all looking for vaccine and stopping the pandemic, because still a lot of people, they hadn't had COVID. So I just, sorry, this thing, okay. So, I mean, my Siri activated. So let me, can you hear me or?
Yes.
Sorry, I just removed the laser pointer to deactivate the Siri. So which skin condition of COVID presents earlier? I'm gonna answer it at the end of the presentation. COVID toes or Tobit, vesicular rash associated with COVID-19, exanthemus rash, urticarial rash, lipidoid rash, or Kawasaki-like syndrome, especially in kids. So this is a little bit about pathophysiology and pathogenesis of this virus. So as you see, there are two areas, like it starts, you know, like from the lung and respiratory tract, but it can go through the, like a milder route, or it can go through the more, you know, cytokine storm and more serious disease. So these are, to me, two different beasts, you know. So people that they get more vascular condition or basically involvement of like the blood vessels and that cytokine storm, they're gonna present differently than the patients that they go with a milder form of disease. And in dermatology, exactly, we have also two types of skin condition. There are ones that they are more inflammatory skin conditions, and there are ones that they are more vascular skin conditions. Not necessarily all the vascular presentation is bad. Like the COVID-2, it is generally a milder form of it in people who have better immunity. So we're going to emphasize that. So about COVID and skin, it started the first reports came from Italy, because in Italy, because of the scale of pandemic, many dermatologists start to cover emergency rooms. And in COVID centers, they were working during the crisis. So they started to notice and basically publish the cutaneous presentation of COVID-19. So as I said, now there are about 200 articles. There are registers by American Academy of Dermatology. And if you see any rash that's related to COVID, like as a physician, we recommend that you actually go to the registry by American Academy of Dermatology, because it's a very good, valuable information for us. The most common rashes are morbilliform, and then papillovesicular, and then urticarial rash. So morbilliform, we all are familiar with those type of rashes, like especially for us that we were like in practice a bit longer, you know, like the rashes like measles or rubella, the rashes that comes with adenovirus, like this type of rash is not uncommon with COVID as well. But about papillovesicular eruption or chickenpox type of rash, also there are reports of it. And then urticaria, that's the most common I've seen during the referrals. I looked into the overall, rates of cutaneous manifestation. There is a wide range. So in Italy, they reported about 20%. But probably that's because a dermatologist was sitting in ER. So they were actually looking at the whole skin, and every zit or everything was recorded. But generally, the report of rash is about 4.95% in the other part of the world. So maybe rash wasn't that specific, or at the time that patient was assessed, they didn't have rash, and when they developed rash, it wasn't like there wasn't any association made by the physician whom basically assessed the rash. So in Italian report, originally they had 148 patients, and they published it in May. So they excluded ones who had recent drugs because they wanted to exclude the drug reactions. They showed that 88 patients with skin conditions, it was related to COVID, and it was about 20% skin manifestation. As I say, it's a bit high compared to the other reports that came after. So, but maybe it's because how they were actually attending the emergency rooms. And 44% they had at the time of presentation. The rest they had after hospitalization. There are more reports coming from other parts of the world, like Spain, China, and now US has the registry for cutaneous findings. There are these 6 main types, and this is important. Like there are 6 main types that we came to conclusion that these are the main rashes we see with COVID. Urticarial rash, confluent erythematous maculopapular or morbilliform rash, papillovesicular exanthemus rash, which could be like chickenpox, chilblain-like acral pattern, or COVID toes, or tovid. Some people like to call it tovid. These are all the new names, like we have tovid, we have mask knee. These are all coming after COVID. The other rash, the fifth form, is libido reticularis, or racemosa-like pattern, which is a vascular pattern, and it can be at some points very serious, especially if it comes like in racemosa or necrosis type pattern. And then we have purpuric or vasculitic pattern that can be also a sign of serious illness. So 6 patterns: urticarial, confluent erythematous, papillovesicular, chilblain-like, libido reticularis, and purpuric and vasculitis. So skin manifestations are like other viral infections. Like, you know, in exanthemus form or morbilliform, as I said, we see it with other viral infections. And sometimes it could be even petechial, like dengue fever. Sometimes it could be very extensive, but sometimes could be very minimal and very localized. Libido reticularis, cutaneous vasculitis, I'm gonna show more pictures. Acute urticaria, I'm gonna show more pictures. And we're gonna talk about COVID toe later. About Kawasaki disease-like presentation in children, the term is pediatric inflammatory multisystem syndrome. And we can even see it in adults, like there are reports of it in adults. And definitely it's a serious condition, and it can be as serious and dangerous as Kawasaki disease. So these are some basically pictures of those rashes, like urticarial rash. I mean, you admit this is not a very typical urticarial, but we, as dermatologists, we like to categorize like lesions, like urticarial rash could be even like erythema mortiforme, like your beginning of like bullous pemphigoid, but it has no scaling and it's like hive-like. But there are times that they really look like urticaria, like acute urticaria. In fact, the most common cause of acute urticaria in children is a viral disease. We don't see a lot of COVID in children, but sometimes they have asymptomatic. And there were, like we have a Facebook group of, you know, and there was one of the physician moms saying, I had COVID, and was showing the picture of her children that they had urticaria-like lesions. So acute urticaria in children is a virus until proven otherwise. This confluent erythematous, like the second picture, it's a bit extensive, but if you look at the upper torso, you see erythematous and, you know, morbilliform rash. The papillovesicular rash, you may notice some vesicles, you know, in this area, for example. Last night, I saw a patient in our ICU and had COVID, like he was on day 21, and I was called for a rash, and it was vesicular. Like you could see some vesicles, but there were also some papules. So this vesicular pattern is reported. It's generally in trunk and torso, like the morbilliform rash is also more trunk and torso. Urticaria can be both trunk and limbs, but the rest of them are more common in the limbs and acral area, like the COVID toe, which is like chilblain-like acral pattern. And I'm gonna go in detail about it. Libido reticularis pattern, which is a vascular form. And then we have purpuric or vasculitis form that come with violaceous. Again, there are many case series now. These are some examples of it. So basically those case series came but remember that they actually excluded very serious patients. So you see in some of these reports, there's no patient with basically libido reticularis or necrosis, because the patients that they could not give the consent, some of them, they were excluded from their series. Also patients who had a lot of drugs, you know, especially serious patients that they had to be treated, they were excluded because they wanted to exclude drug reactions, and also they wanted a consent from the patients. But gives an idea, like in 375 cases of cutaneous disease, like in Spain, like 73 had urticarial, which is 19%, 176 morbilliform, 47%, and then papillovesicular, 34 or 9%, and the chilblain, they had 71, 19%, and so on. So that's like again in detail of the Spanish study, which was also very well organized. So this is what they came like. Acral erythema with vesicles or pustules or pseudochilblain. It's more common in younger patients. On average, it comes 12.6 days later. It may be painful or itchy. Like generally chilblain, the usual chilblain that is not like, that's something we commonly had seen like before, comes like in countries that they have temperate temperature, and it comes in the fall or winter. But for this chilblain related to COVID, it doesn't have that rhyme and reason. It may come even in the summertime, and it may have a course of, a recurrent course. So I'll show it later. We call it even a long hauler. Like these are things that they may last a bit longer. And 59% after the acute symptoms is gone. So it's something that probably family, like I had few cases referred to me, all from family doctors. So those are the patients that some of them, even we couldn't get the positive COVID test, but we knew that they had COVID. And like a couple of them, we had positive COVID tests, but it's interesting, like since March, it was coming and going. So it has a fluctuating course. So vesicular and even hemorrhagic, it may come early or before onset, or urticarials, 19% on average, about 6 days, but it may come even before COVID started. And these patients, strangely, they have more severe courses. So like between like mid to high intensity of the disease. So maculopapular rash, as a physician, like we know when a patient is sick. So if a patient is not sick and I see a maculopapular rash, I wouldn't like lose sleep over it, because it's not uncommon in the context of COVID, and it doesn't give me any prognosis, pattern for this patient. Overall, the case fatality in the Spanish report was 1.9%, but they excluded very severe cases because they could not give the consent. So because some of our colleagues in this round are pathologists, I just brought some of the examples of pathology. So this disease, like COVID, has very strange and interesting effects on the body. Even on the skin, not all the pathophysiology and pathogenesis, like how it causes skin condition, it's the same. So it's not very uniform, even the way that presents on skin. So the first one, the A, is urticarial rash. So the B is the confluent erythematous maculopapular or morbilliform. C is chilblain or acral lesion. And D is purpuric and vasculitis pattern. So even in pathology, it may come with different presentations. So let's go on urticaria and angioedema, because as I said before, it can be triggered by many viral and bacterial agents like cytomegalovirus, herpes virus, Epstein-Barr, mycoplasma. So patients that they come with acute urticarial disease, especially like in children or even in adults, sometimes we have to rule out viral things. In terms of COVID, 16.7 or 19, like different reports. So about 19% of patients, it may be a skin manifestation for COVID. It may come simultaneously with systemic symptoms, or it may come before or even after. And on average, it lasts about 1 week. So medium to high severity of COVID-19 these patients have. They may be very itchy and generally involves trunk and limbs, and relatively spares the acral sites. So the treatment that recommended was a low-dose systemic corticosteroid, which I rather not to give. Like, we know that high dose of a corticosteroid may affect the prognosis, unless a patient is really sick and we have to go to, like when there's that cytokine storm, then, there are different options. But I generally treat them with a non-sedating antihistamine. And that's based on the recommendation of some of these articles as my references. So if patient is bad, maybe give a short course of low-dose systemic steroid plus non-sedating antihistamines, like, like Reactine, Blexten, or Rupall. To me, higher doses of Reactine is still sedating. And these are the three that we can prescribe. And there are ones that the patients can pick up over the counter, like Allegra or Arius, but they are not necessarily have better, result than the ones that we prescribe. So they recommend that, and that's like we treat them symptomatically, like not more than that. So let's go back again on some COVID-2 presentation, because I think it's a very interesting, area. Like at the beginning, when came to the world of dermatology that we have COVID-2 or TOVID, we thought it's another chilblain. But later on, we learned it's not really another chilblain. And it's very fascinating how this virus acts on our body. So these are some pictures of it. Like you see different looks. Sometimes it may even look dermatitic. Sometimes it may look like ecchymotic. And it can be painful, and it's because of painful inflammation of small blood vessels on fingers or toes. And it could be a reaction to cold. Like this is the general chilblain, but in these cases, like we've seen before COVID, like in Canada, like we have like the, if like we see chilblain, it could be also other things, not always everything is COVID. Previously we were dealing like with, when we were dealing with chilblain, we had to rule out lupus, multiple myeloma, anorexia, malnutrition, coagulopathies, and other things. But now, as I said, like this is an interesting entity. This is a recent article from Lancet in January they published, and the appendix was about this COVID-2. So they were going, and they call it a long haulers in dermatology, like COVID-19 long haulers, because there are a few things that, as you know already, they may last longer. One is fatigue with COVID, and the other one, this COVID-2s. So they looked at the population that they get more COVID-2. So the thing is, it's more common in younger, like patients, maybe a bit more common in female, and more common in white compared to the other races. And not necessarily, like it's generally in healthy adults without any comorbidity. This is very interesting, or at least it's interesting to me. So they looked at this COVID-2 and perniosis. So at the beginning of the disease, like patient had fatigue and cough, day 7, around day 7, this perniosis started. So then they did the testing. Sorry, it's a bit because I did screenshot, it's not very clear, but between day 7 to 20, PCR was positive. Then they had, they didn't have the antibodies still positive. And then basically later on, they had worsening of pernia. As I said, like there's a fluctuation in this disease. And at that point, they saw IgA was positive, like anti-spike or anti-RBD was positive. And then, they had also, like they followed these patients, and they had ongoing fatigue. And then later on, IgM became positive and IgG negative, So these patients were IgG negative, IgA positive at the peak of the problem, So, but again, even they followed up to day 133, and they saw that the fatigue was improving, but they had persistent pernio coming and going. And in a couple of patients I followed, this is exactly the pattern happened. So it's very interesting. So they call it long hauler, but again, it shows that this disease has a lot of surprises for us, like the fact that IgA spike, anti-spike is positive, the fact that it lasts so long, you know. And I know, like, from other point of views, our other colleagues, they are also seeing other long haulers in this disease, like, you know, some neurologic symptoms, fatigue, or other problems. So this is again plasma IgA binding to SARS-CoV-2 receptor binding domain, that they show it may go higher, and they basically compared it with controlled with the disease and without disease, and that was interesting finding in COVID toes. So again, more photos of the COVID toes from internet. But I guess exactly like my patients, like sometimes you look at it and you feel like it's dermatitic, you know, like this picture here, it's not very purpuric. Like these ones, they look purpuric, but sometimes they are like, they look like an ingrown nail, or, you know, a traumatic nail. They don't look very typical, but that is also fluctuations in the course of this disease. And you may see it also in fingers too. So let's now focus on another type of rash, confluent erythematous or maculopapular or morbilliform rash. As I said, it's the most common presentation, and it may have a variety of pictures. It may look like erythema multiforme. It may look like even like pityriasis rosea. It may look like more, you know, skin-related conditions like erythema elevatum duodenum. It may be perifollicular. It may be generalized. Like we had a case that I was called to go to emergency, like for a patient, and at that time we didn't know that she had COVID. She had generalized rash and she had pneumonia, and she had been, like she said, she had pneumonia, and she was treated with antibiotics. So I mean, it looked like a severe drug reaction, you know. But then later on, we realized that she had COVID. So, and I followed her, like a month later, the rash was gone. I mean, her COVID was better. So no sequela or no problem. So different form of exanthemus rash, you see, it may be very non-specific, or it may look even dermatitic. So basically any rash that comes with COVID, like the rashes that I thought even they look like molluscum, you know, I mean, some of them I saw virtual, I thought it's molluscum, but then we realized patient had COVID and the rash was gone. So anything could be COVID until proven otherwise. So it has a wide range of presentations. So now let's focus on the vascular lesions and coagulopathies and vasculitis. These are the rashes that make me worried, because we know that there is a serious underlying thing, you know, a vascular presentation, maybe microthromboemboli, or when a patient is sick, especially if it comes with skin necrosis, could be a sign of cytokine storm. So livedo reticularis is a very familiar pattern for us. You know, it is basically problem with the lack of oxygen, with the blood flow. You may see it in certain connective tissue disorders like lupus, polyarthritis nodosa, but even like people that use heaters on their back, you know, it may affect their vascular flow, and you may see that kind of look on their back, or people use computers on their lap, you may see this, or even people using their, you know, the heat for their seats during winter, you know, you may see this pattern on the back. So it's a vascular pattern. So it also has a range. So if it comes like just mild form, it's like part of COVID, but it shows that there is a bit of microthromboemboli and vascular pattern happening with the COVID. So we have to look and monitor more carefully. But it may come more serious, like more vasculitis-like pattern. And it may come even with a skin necrosis pattern. This patient is definitely some like patient that I'm gonna, you know, lose sleep over it, because we know that there's an underlying issue there, multiple probably other, like there are other factors, you know, microthromboemboli, you know, vasculitis and other factors going on. And these are generally cases in ICU. So, I mean, there are other presentations with COVID. As I said, like patients may come with pityriasis rosea-like rash, and they may come with even more serious forms like multi-system inflammatory syndrome in children and adults. One common thing that I see is anagen and telogen effluvium. So people may come and present with hair loss. So when patient is very sick, you know, they may come even with anagen effluvium, like, and that's very scary. They lose all their hair. But when the disease is over, so it's not uncommon to get telogen effluvium after any serious illness, including COVID. The problem is some of these rashes, you know, not necessarily, or so some of these may not be temporary. Like if a patient has an underlying issue and loses hair, they may not be able to recover, you know. So hair loss, you know, telogen effluvium supposedly has to go back to normal, but with patients that they have an underlying issue, iron deficiency, anemia, I don't know, like androgenetic alopecia, or hormonal things like they are after menopause, they may not kick back, they may not be able to regain that hair. So there's a form of also a variant of it like Rover disease, very itchy disease. We see a lot in elderly. So it may come, they may look like herpetic. So as I said, like there are a lot of manifestations. Still, we need more to learn about this disease. So those registers is gonna help. So this is again summary, like there are 6 major patterns: urticarial rash, confluent erythematous, maculopapular morbilliform rash, papulovesicular or chickenpox-like rash, chilblain-like or acral pattern or tovid or COVID toes, livido reticularis or racemosa-like pattern, and then purpuric and vasculitis pattern. And there are others, like, you know, other presentations too. So this is like a presentation of Kawasaki, like the actual Kawasaki. And this is a case from, I think it was from Quebec, with Kawasaki, like pediatric inflammatory multisystem syndrome. So we go over a bit like what are the presentations of Kawasaki. They have fever, they may have the lymph nodes, they have arthritis or arthralgia, and they have very red, chapped, cracked lips, and they have conjunctivitis, and the acral part, whether they have swelling and edema, and then later they may get peeling of it. And these are, this is a serious illness, as you know, because it may affect the heart. And again, even in the form of related to COVID, may have that complication. So if you come with a case, even in a child comes with these symptoms, that patient needs to be referred to emergency. So those were kind of COVID virus-related rashes. Now there are things that they are external, as you know, like PP-induced rashes, like all the pressure ulcers, you know, like we can see what we call maskne or mask acne around the mouth. I see a lot of periorificial dermatitis and or acne-like symptoms around the mouth because of the use of PPE. There are even certain device like dressings made to seal under the mask to kind of hydrate, moisturize, but doesn't affect N95. Like these are people that they wear N95 for hours and hours, you know. And this is one of the most common, you know, problems or referrals I get. And even patients ask to give note or like disability note, and that's actually hand dermatitis, like because of washing too much, you know, irritation, you know, hand sanitizers. Sometimes it's basically irritation to alcohol or hand sanitizers, or sometimes it's contact allergy to certain, you know, fragrances or things added to the hand sanitizers. So that's also another issue. Like if a patient cannot tolerate alcohol-based hand sanitizers, you know, there are forms like 3M. It still has alcohol, but it's more creamy. Or we ask to use soap and use right away a moisturizer, like a bar soap and then a moisturizer after. Although it seems that if people use moisturizer like all the time and then use the soap, it may not be as good disinfectant. We have other challenges in dermatology, like with COVID, in the world of COVID, like for example, we have a lot of patients on biologics. So our consensus, we continue the same management. Biologics are fairly safe. But the thing that showed in our recent literature, high dose prednisone may affect prognosis. And if we want to start a patient on high dose prednisone, we have to think twice, especially if a patient is prone. And if a patient is going under vaccination, that may also affect the effect of vaccination. The other things about immunosuppressant, again, there's a bit of debates, but some, based on the rheumatology data, recommend to stop. I mean, these are all based on the flu vaccine before. Like it showed that people, for example, getting methotrexate, if they get the flu shot, the antibody response is not the same. So some recommend to stop methotrexate 2 weeks before until 1 to 2 weeks after. But it depends on the patient's level of, like the degree of the illness. So we don't know how valid is, like what's the clinical relation, because they may not develop as much antibody, but still may have enough immunity against the vaccine. But myfortic, Imuran, tofacitinib, which is JAK inhibitor, they may actually decrease the immunity and increase the chance of like more serious illness. So whenever we want to start these drugs, we have to weigh, pros and cons and risks and benefits. And it's a big challenge. I don't know, somehow I'm seeing more bullous pemphigoid, and it's very hard, like in an elderly, whether to start myfortic or not, because we know it may affect their prognosis. And also like high dose of prednisone, sometimes we have to use, but there's also a risk. So far, methotrexate showed safer, and even patients that, like in registries, they were getting methotrexate. It seems the ones that got COVID or contracted COVID, even they had better prognosis. But rituximab is a drug that we have to be a bit careful, because it may increase, like, as I said, like chance of, the vaccination may not work in that case. And also this is a drug that it may affect the prognosis of a patient if they get COVID. So, and the last part is we may have also drug reactions when somebody has COVID, like when we give like a lot of drugs. So we always have to think of also there's possibility of drug reactions, like fixed drug reaction, urticaria reaction, or exanthemus. So the COVID rashes, they are not just COVID. It could be also external from PPE or hand washing, or also it could be drug reactions related to COVID. So I go a bit, again, emphasize on urticaria and COVID. These are some pictures from the net, that I found from internet. So it may come in different presentations. If a patient comes with acute urticaria, think of COVID, especially at the time of pandemic. So I just want to, at the end, just talk a bit about acute and chronic urticaria, because during the COVID time, this is one of the most common referrals I got. And it's sometimes hard for me, like, to know whether it is or not. So I ask patients to be tested, but not in everybody. Overall, acute urticaria is up to 6 weeks. Most common cause in children in viral. Most common cause in adults could be food, drug, or viral. It's generally self-resolving. Generally, we treat it just symptomatic, like with antihistamine. Generally, topical treatments, they are not as effective unless, like, you use a bit of pramoxetine or something to calm down the itch. And we generally don't like to give oral prednisone unless we don't have any other option and patient is really devastated. So we may give a very short course of a low dose prednisone for a few days. Chronic urticaria is different story, and that's not probably related to this subject. But remember, if a patient has urticaria more than 6 weeks, there are other possibilities. And the most common cause is chronic spontaneous urticaria. However, sometimes, like, you have to ask, is it triggered by cold, pressure, heat? But if the patient doesn't have any of this, that chronic spontaneous urticaria, majority of time is we don't find any reason. And it may be accompanied by angioedema. And it has a variable course and sometimes could be very debilitating and devastating. We generally don't do a lot of blood tests. We may do ESR and C-reactive protein and CBC with differential and measure the disease activity and exclude differential diagnosis. So this is a busy chart, but I go quickly. Like if a patient comes with angioedema alone, it's a different story. Whether ACE inhibitor or other treatment, or if they don't have ACE inhibitor history, then it's probably genetic. So that's a different story. But if a patient has angioedema and urticaria together, it's like in the range of urticaria. So if a patient, and we are talking about chronic now, like this is separate from COVID. So if a patient comes with urticaria and fever and body pain and other symptoms and it's chronic, we have to rule out acute acquired hereditary, or autoinflammatory diseases. So that's a different story. But if a patient comes and urticaria lasts more than 24 hours, we generally do biopsy to rule out vasculitis. So if a patient comes with urticaria, angioedema, no fever, not lasting more than 24 hours, and it's not inducible like with cold or others, then that's chronic spontaneous urticaria. And as I said, it's something that I get a lot actually referral from emergencies. And how we treat, this is the guideline. We start with antihistamines. Second generation, we don't give first generation of antihistamines anymore because of the side effect, it may affect REM and it may affect, it may cause torsades. So we don't give first generation of antihistamine. For second generation of antihistamine, after 2 to 4 weeks, if they are not doing well, this is in chronic urticaria again, we may go up to 4 times. So 4 times regular dose. So if the dose of Reactine is 10, we can go up to 40. If the regular dose of Blexten is 20, we can go up to 80. If for Rupall, the same, we can go up to 4. So this is like the guideline. We go up to 4 times the dose. And then if the patient after 4 weeks is not doing better, then the next is omalizumab or Xolair. And that may make a difference, like even up, like generally I get always things back from pharmacy, why like this dose it's not recommended or things like that. But, this is the guideline. And, then the next is cyclosporin. So in Canadian guideline, they may add basically singular or a prednisone, for a short while. But the international, they don't even have those, So again, back to this, so if a patient comes with urticaria, even in the acute urticaria, you may increase the dose. So among the second generation of antihistamines, the one that we prescribe, I feel like if you go really higher in the dose of Reactine, patients may get really, really drowsy. So it's not always non-sedating. Rupall has a lot of interaction. It's a good drug, but you have to check with CYP3A4, reactions and make sure there's no drug-drug interactions. But that's another option. And then Blexten, which is one of the newest and is kind of my go drug. So my talk is done. I just have some extra photos to go if people like, but I'm open to questions right now. Any questions from the audience? Dr. Mastro-Giacomo, you can unmute yourself and talk, yes.
Thank you. So I posted something on the chat. I saw a girl recently virtually over OTN and she had chilblains of her toes. No other symptoms. I mean, I thought of COVID toes, but it was going on since October. She was playing tennis in a cold tennis arena indoors. And I thought it's chilblains. So now listening to you, could she have been a long hauler? Yeah, with COVID, even though she had no symptoms other than this. And what should I do now? Because I didn't test for COVID.
I mean, it's interesting. And probably if you test, you may not even get a positive result. I would ask first thing, did she have, like, if she's a tennis player, did she have these symptoms the years before? Because if people are prone, it's very likely to be COVID. But, you know, there are times like people like, especially like we may see chilblain or perniosis in people who go on diet, you know, like people who get anorexic, you know. So there are other factors too. But given the pandemic, everything is related to pandemic until proven otherwise. And among our Derm Society, when we talk, like there are a lot of reports, our friends and colleagues bring reports of like patients that they test were negative, like, but they were exposed to COVID. Like one of them like was working in an office that co-worker had COVID. She was a young woman, she never had even symptoms and started to have this like chilblain, very, very unusual form, you know, even like continued in summertime. So that's one of the things that it really brought to our attention. It presents different than the usual chilblain that we see, you know, that is generally during the fall or early winter and then gets better with warming up, or, you know. So I think this is, to me, COVID until proven otherwise. But in the cases I had, like, I just, wrote back to family doctor, I think it's related to COVID, but you can test the patient. Like at that point, you know, even if we get negative antibodies, not necessarily we can rule out. And the interesting thing that I showed there, it's IgA positive in the, you know, pick of COVID, which is interesting. Like it's a different type of antibody.
Thank you.
You're welcome.
Dr. Hessami, we have another question from Dr. Rose Reisman. If a patient is COVID negative, can it still be COVID due to false negative?
I mean, that's probably a better question for our infectious disease specialist, but my understanding is every test has false positive and false negative. So that's possibility. Like, where do you, where in the basically range of COVID you are testing this patient? Like, are we doing both PCR and, you know, antibody testing? But I think this is a better question to be asked our infectious disease. I don't know whether Dr. John or Dr. Levinsky is there in the group. I cannot see the whole participant, but please feel free to answer if.
I don't see them in the group.
Oh, sorry. Yes, I'm here. Susan John. So what was your question again about whether it's a false positive test? I mean,
false negative, basically. So do you want to read, Risha, the question?
Yeah, can you repeat the question?
I can ask the question. If we see the patients with look like COVID toes and they say that they're COVID negative and they did the test, can we still assume that it's COVID toes if we don't find anything else? Because sometimes tests are negative because it's long time past or because false negative or sensitivity. This is a question.
Yeah, definitely. So we've seen a lot of possible negatives. Although the test has a high negative predictive value, the PCR test, it's very possible, especially in these patients with chilblains or chilblain-like lesions, where often the test is negative. So it's very possible that the test can be negative, but the patient had COVID, or the manifestations are only these toe lesions or toe rash.
Thank you.
Susan, do you check for IgA or no? Like, what's the routine of the antibody testing?
No, I rarely check it. It's just in those people that are in hospital, for example. I rarely check in the community. I mean, you have to pay for it. So if the patient wants to pay and desperately wants to know, fine. But in the hospital, I have checked in patients who, you know, we suspect like that the multi-inflammatory syndrome. Like I had a young patient recently who I suspected that MIS syndrome. So I did check, but no, I believe they just do IgG. They don't do IgA. I haven't seen IgA done. I don't know if Rena's on the call and she knows, but I have not heard of that being done.
I saw Rina at hospital. She said she tries her best, but it seems she couldn't make. So the question is, if somebody wants to pay for the test, where can they do the test? Like, what's the routine? I mean, probably it's a, but probably others.
Yeah, I believe
know,
Life Labs. I believe Life Labs is offering the test. You just have to pay for it.
And do you know how much is or no?
Oh, you know what? I'm not sure. That's a good question. I think it's around the range of like, you know, at least maybe 100 or close to 100, but I don't know. I'm guessing. So that's just a guess. I can get back to you on that.
Very good. Thank you. Any other questions, Risha, from the audience?
Not from the audience, but I actually had one when you were talking. I was curious about the antigen effluvium and blood effluvium. How common is that in COVID, and what's your management approach?
Oh, that's a very interesting question. Like it's reported, I hear a lot. I had a lot of patients, but to me right now, hair loss is an epidemic anyway. Everybody has hair loss. What is going on? What are we doing to our environment? Is it stress or who knows? But telogen effluvium is not uncommon after stress, you know, after any serious illness. But I read in this, when I was actually reviewing a lot of articles last night, I found anagen effluvium reported, which, you know, like I see Dr. Krieger here. So, you know, like people do chemotherapy and patients, they know anagen effluvium is something serious. Like patients really lose all the anagen hair right away. And that's, I had a patient that at the time of COVID, she said she lost all her hair. So I assume that was anagen effluvium in that case, you know. But I think part of this, like I presented in this run to increase the awareness, you know, from every pimple rash that new to a patient to COVID toes, even months after could be related to COVID. So just we increase the awareness, like hair loss could be related to COVID. Urticaria as one of the most common actually referrals that I get could be in acute phases, could be related to COVID, to very serious illnesses, to MIS that we don't want to miss it, you know.
Thank you for going into detail for that. It's good to know. I do want to add that Dr. Terrence Lung has said that the COVID test is $75 at Dynacare.
Oh, very good.
Yeah, I think Dr. Susan John was asking as well. We have a question from Dr. Kapil Kohli. He says, hi, for COVID, patients are on DEX, or I don't understand that, for serious symptoms. Does this help or decrease prevalence?
Do you want to unmute and ask your question, Dr. Kohli?
Yes, hi there. Can you hear me?
Hi. Yes, yes.
Yeah, perfect. So I'm just calling, there's a lot of patients now with COVID, with the early, especially in the elderly population, we're using more and more dexamethasone for various respiratory symptoms. Is there prevalence studies, or does that make any difference? It worsens the symptoms of cutaneous manifestations, or does it help? Does it prolong things? And just a sequelae of, is there any observations of what all these other medications we're using is doing to the cutaneous symptoms?
So it's a very interesting question. Like, let's put it like this way. In October, in our Journal of American Academy of Dermatology, they had a review of what drugs we use generally in dermatology and the effect on COVID. So we use prednisone, but dexamethasone or other steroids, like, you know, probably on the same boat. So again, if you use a low dose, probably it doesn't affect the outcome of the disease. In terms of cutaneous manifestation, it may help, or especially for the milder forms like or urticaria or, you know, papillo, like, you know, we use this sometimes to calm down the skin. But then we have two phases for the cutaneous manifestation. When it comes to the serious forms of COVID manifestation, then it's totally a different beast. Like, you know, as I said, like we didn't have any data, or we didn't know what to say about our patients on biologics, methotrexate. But then studies showed, in fact, patients that they were on those and they ended up to ICU, they did even better. So they were like some studies that they, you know, like a patient ends up to ICU, you may go with a higher dose of, you know, steroid. But we don't recommend the high dose of steroid if we can avoid, you know, for patients that at the beginning of COVID, because it may increase the chance of having more like serious or affects their outcome. So if it helps the skin, yes, because, you know, like with inflammation, you give steroid, definitely it can help. Do we recommend not high doses? Are we worried about methotrexate, Humira, or, you know, like anti-IL-17? No, at this point, we are very comfortable with these drugs. Are we worried about Myfortic, Imuran, you know, rituximab, tofacitinib? Yes. You know, so we have like a basically a risk-benefit you know, way to see which drugs we can go. But symptomatic, like always, like it's okay to use a topical steroid or give like a antihistamine. Like I'm not worried about those drugs, basically. Did I answer your question?
Yes, thank you. And just yeah, so in relation to that, I was gonna my second question was about the patient with the bullous, and we have a lot of patients, especially geriatric patients, on chronic steroids and chronic immunosuppressants. So I always wonder if they do get acute COVID infections. We tend to hold, or I tend to hold these medications temporarily, but I don't know I don't usually add topical creams unless needed, but I wonder if that's a better idea, maybe to add topical creams while we're holding the oral medications.
I mean, that's a very interesting question, because I'm on the same boat. Like we deal with a lot of bullous pemphigoid elderly patients. It's not an easy decision, you know. So if you stop, like we had a patient that she had bullous pemphigoid, somehow she stopped her medication. Like she was on prednisone and Myfortic, yes, Myfortic, and she stopped it one day, and she ended up to have all blisters. And she was admitted to the hospital. I'm not sure Pega, Dr. Shah is here today or not. She was taking care of the patient and she got very sick, you know. I'm not sure what was the reason that she passed at the end. So these diseases, if we stop their medication, first of all, affect their quality of life. Two, there's always chance of, you know, infection, electrolyte and water imbalance. So again, it's like a risk and benefit, in a way. You know, I like if a patient is not really, really highly at risk, I continue their medication. If there is any chance of like COVID, I may stop it at the time that they get COVID, and then. But with methotrexate, so far, unanimous decision in dermatology world is we continue, because so far the evidence and registries didn't show worsening of prognosis. With high prednisone, I stop, but with low prednisone, I generally continue. And adding a topical, you know, strong corticosteroid like clobetasol is always another option.
Great, thank you very much, and thank you for the great talk.
Yeah, thank you. Thank you. I think it's 1 o'clock, so we are done. So I had, you know, a few cases that I'm not going, but I always end up with Stevens-Johnson because I feel like this is my role to make sure if you are a prescriber and you use any of the drugs that they may cause Stevens-Johnson, be aware of it. And this is a mnemonic for it, like these are some common drugs: sulfasalazine, allopurinol, tetracycline, minocycline, anticonvulsant, carbamazepine, dilantin, lamotrigine, phenobarb, nevirapine, NSAIDs, like we say, the mnemonic Satan. And especially in our population of patients, like Han Chinese, like with allopurinol, this can be tested, the HLA B5801. Be careful. So if patients are started on any of these drugs 2-3 weeks later, 4-6 weeks later, they may start to get symptoms. Skin symptoms, conjunctivitis, mucous membrane involvement, fever, and, and if it happens to anybody, like all the family, they want to be tested because this is so serious. Even recently, we had 2 cases in Birchmount. I don't even cover Birchmount, but somehow I was involved in their cases. So we had 2 cases from Birchmount, 1 from Centenary. So just be aware of it. And carbamazepine is another one. Lamotrigine is a rising star. So be careful. And, there is HLA testing available. So in your patients at risk, you can basically ask to be tested before start. Or if you start, watch and follow basically very carefully. Thank you.
Thank you, Dr. Hessami. There was a lot of great information that you shared today and the different types of rashes that we can see in COVID-19. You also mentioned the American Academy of Dermatology and the various PubMed articles. I was just wondering if you have any other resources that we can recommend to family physicians or even other dermatologists to reference that.
I suggest and I recommend anybody sees a patient with any rash related to COVID, basically go to that registry and register. You don't need to be a dermatologist to register, but that helps to get an understanding. To be honest, I don't think it's as much as other symptoms. I believe that 5% is about right, So during all this time, and I was available to do consults at hospital, I didn't see a lot of serious rashes with COVID. There were some rashes, some generalized rashes. But as I said, there are 2 forms of rashes. The one that they are more serious, like the vasculitis, necrosis. Those are the ones that we have to make sure monitor, send to emergency, and then the other ones we can basically do symptomatically. But basically going to references, even honestly, you do Google search, a lot of good references, they come. Like PubMed, they has a lot of references. And I have 3 references here that I found. One was systematic review, and I really liked it. And I myself, I prepared this talk previously in June or May, June. I presented first to emergency doctors and then a group of family doctors. But a few months later, when I went back and I read the literature and also attending our talks in the world of dermatology, I see a lot of reports from our colleagues and kind of reinforcing this knowledge. But again, we have to have an open eye. And if a serious thing comes, sometimes that's the way we learn from each other, because this disease still has a lot of surprises.
Yes, absolutely. Well,
thank you very much.
That's good to know. Thank you so much. And there's a few physicians that have said, great talk. Thank you so much, and very enlightening. So thank you so much for your time today,
Thank
Dr.
you.
Hessami.
Thanks a lot. And thanks for everybody to inviting me and giving this opportunity to share the experience.
Thanks, Dr. Hessami.
Thanks for attending.
Thanks for
attending. Thank you very much.
Thank you so much. Have a great day, everyone.
Bye.
Bye.
Bye.